This is after lunch, and so let's start with something very simple. Start with the simple case history. This is the kind of most of you, almost all of you are busy practicing clinicians working in busy medical wards. So this is the kind of thing that you would see every day. Young man coming with fever, headache, and drowsy, and coming in after a seizure, and he has neck stiffness and bilateral pyramidal signs. Bread and butter for all of you. So the simple question that I would ask you, so just to wake ourselves up, try and answer, please. Right, what is the likely diagnosis? This is what you will be asking your medical students every day on the ward. So what do you think that would be? Any thoughts? No? All line hibernation? Okay, right. Can it be bacterial meningitis, anybody? Yes or no? Viral encephalitis can be an abscess, can be TB, can be even malaria, even though we just heard about malaria, even though we don't think that we see it here anymore. Perhaps the more important question would be, how will you manage this patient? Easy. Again, you would say, this is how you would manage any patient. You would first do a proper clinical assessment, then do some investigations to establish the diagnosis, and then in some logical manner, we would work out the treatment. Right, so what's the fuss about CNS infections? What we know is that the CNS infections lead to large numbers of deaths and large numbers of neurological sequelae. Whether it is bacterial, TB, or viral, it's the same thing. Lots of deaths and lots of disability. What we have also learned is that delays in treatment would increase mortality and the residual neurological deficits. And the converse is also true, that early treatment saves lives and minimizes residual neurological deficits. But the problem in countries like ours, the developing world, we have just been upgraded to a low-income country from low-middle income. So countries like ours, the challenge is that CNS infections are a lot more commoner, whether it is bacterial, whether it's TB, whether it's viral, malaria, and they lead to more deaths, almost 50% mortality, and more neurological deficits in 50% of the survivors. So that's where the problem lies in our countries. And there are many reasons for that. We know there are so many barriers to early and effective treatment. But at the end of the day, we have lots of deaths and lots of disability in our countries due to CNS infection. So we need to start treatment early to save lives and minimize the deaths and disability. So how do we do that? Because time is so precious in the management of CNS infection, we simply do not have the luxury of doing a staged clinical assessment and then doing the investigations to come to a diagnosis and then thinking of what we are going to do in terms of management. We simply do not have that luxury. We have to do all that together, save time and save lives. So how do you do that? So to start on early and appropriate treatment, you need rapid and accurate diagnosis. So let's look at how we can do that. Let's start with the clinical evaluation. Go back to our patient, right? Young man with fever, headache, seizures, and neck stiffness and some bilateral pyramidal signs. Can it be bacterial meningitis? Can it be a viral encephalitis? Same question that I'm asking again. Right. All you can say with that patient in front of you, say on Monday morning when you go back to the wards, during your Monday morning ward round, what you will be able to say is that all you can say is that he has a CNS infection. Because he will have features of meningitis, meningeal irritation like fever and headache and neck stiffness. He will also have features of an encephalitic component, altered consciousness, seizures, pyramidal signs. So all you can say in most times would be that it is just a CNS infection, undifferentiated CNS infection. Because patients present not with meningitis or encephalitis or abscess, most of the time they present with the meningoencephalitis. And it's important not to confuse two things. One is the syndromic diagnosis of meningitis or encephalitis or an abscess against the etiological diagnosis, whether it is bacterial or viral or TB. So we need to look at both these things. So when would you think of a meningitis? Looking at just the simple clinical features. There are so many clinical features. These are the key ones that you would look at. So people have done that. So what they have found is that the classical triad of fever and neck stiffness and altered mental state are seen in less than half of the patients with meningitis. But the important thing perhaps is that at least one of them will be there in almost everybody. And if all three of them are not there, you can basically rule out meningitis. So the clinical features are much, much better in ruling out CNS infection rather than ruling in CNS infection. Similar study sometime later, which again looked at the key clinical signs that we elicit and teach our students, neck stiffness, Kernicks, etc. Very low sensitivity and very low positive predictive value. So they are much better ruling out CNS infection rather than ruling in CNS infection. So what we have learned is that clinical assessment is difficult. So how can you establish the diagnosis? So that is a challenge. So Prof. Ranawaka, who is a microbiologist here, would tell you that you diagnose any infection anywhere in the body by isolating the organism. So if it comes to CNS infection, you need to isolate the organism, preferably by culture. So the easier thing that we do is in the CSF. There are other things that we can do which can give us some idea what it is likely to be. Things like the CSF cytology, glucose and protein levels, etc., and also blood culture. Very important, blood culture. How good are they? So what we have also learned is that CSF cell counts, which we usually go by to start treatment, can be normal or just slightly elevated in almost up to about 20% of people with bacterial meningitis. Does that matter? Yes, because some of them are the people with the worst possible outcomes. And up to about 10% of patients do not have any CSF findings suggestive of bacterial meningitis. And there's no single CSF variable that can rule out bacterial infection in the CSF unless you do a culture. So culture, you come back to the culture, which is the gold standard for diagnosis of CNS infection. But then when it comes to countries like ours, we know that our diagnostic yields are rather low. And it's the same pretty much everywhere. Largely, we attribute them to lack of diagnostic facilities like PCR testing and a lot of prior antibiotic use. We know that many of our patients have been given antibiotics before they come to hospital. But if we look at the data a little more carefully, if we look at unselected samples of patients who presented, just like the patient we talked about, unselected patients with the presumed CNS infection, many of the studies, even in the developed countries with very good diagnostic facilities, still have low diagnostic yields. Just give you a few examples. So first one, a multi-center study in UK, more than 200 patients, they were able to confirm a diagnosis in only about 20%. Large study from Finland, less than 50%, they were able to come to a diagnosis. Another multi-center study in UK, in encephalitis, suspected encephalitis, only 40% had the infection diagnosed. And the California Encephalitis Project, one of the best documented case series, more than 1,500 patients, and where they had access to all the sophisticated testing under the sun and possibly from some other galaxies also, they were able to pick up an etiological agent in only 16% of cases. So clearly, there's something that we are missing. throughout the world, 85% of cases of CNS infection go undiagnosed. So there is a problem there. So then, if we can't establish the diagnosis, how are we going to treat? So we have to start antibiotic treatment on an empirical basis. Basically, guesswork, but how are you going to do the guesswork when you have a patient like this in front of you? So this is your patient. So what drugs would you use? Let's wake up, ladies and gentlemen. Anybody for penicillin? No? Third generation cephalosporin? No? Okay, thanks. Some people, at least happy to say that everybody is not bilaterally quadriplegic, okay, right, okay. Vancomycin, maybe. Meropenem. Every UTI in this country gets treated with meropenem, so why not CNS infection? Anybody for acyclovir? Okay. So the best guess empirical treatment would depend on your epidemiological data in your community, in your setting, which is usually not available in developing countries. So what do we know about CNS infections in our country? Until about a decade ago, we had only few case reports and a few case series on isolated syndromes, and there were no prospective studies. We did the first prospective study on CNS infection in Ragama, where I work, about a little over 10 years ago, where we studied all the adults with suspected CNS infection admitted to all the medical units over a 2-year period, for about 200 patients. What did we find? Precious little. We managed to detect CNS infection in only one patient, and that again with a blood culture. So there may have been many reasons. There may be problems with sample collection, the way we stored the samples, sample analysis, delays in investigation, a lot of other things, the lack of facilities like PCR, and many of them, almost 1/3 had been given antibiotic. There may have been many reasons, but still less than 1% is a serious problem. So we were really bugged by the lack of bugs in our study. So we did a follow-up study, this time with all the adults and all the children, again over a 2-year period. Did we fare any better? Very slightly, up to about close to 3%, where we were able to identify an infection. Positively document CNS infection by a culture or some other method. 8 again by blood culture and serology, and 1 PCR. PCR was not routinely available, so this is something that was done in the private sector. But we went beyond that and collaborated with the Udaya University in Japan to test for bacteria by PCR and lots of viruses by PCR and anti-NMDA antibody testing. And found a few more reports where we were able to come to a diagnosis finally in about 6% of patients. So what have we found in this country after that? There have been a few other studies. So this is 39 CSF samples in 2 tertiary care hospitals where they were able to identify 9 echovirus, all in children, all by PCR. All other viruses, bacteria, everything was negative. Second study, 99 CSF samples, again from 2 tertiary care hospitals in Colombo, again over a 2-year period. They were able to identify a viral etiology in 27%, a lot better than what we did, but this is a little later and with a lot more emphasis on PCR testing. So all these were on PCR. A third study, 108 children in 1 tertiary care center, where they were able to culture 5 out of 40 samples, and multiplex PCR testing, they were able to identify 31 out of 50 samples. And the most recent one published last year, 80 CSF samples from 1 center. All the cultures were negative, all antigen testings were negative, multiplex PCR testing where they were able to identify 8 positive cases. So end of the day, we have very little data to go by. right? So you have to start treatment on empirical basis without much data. So this low diagnostic yield, what does that really mean? So this is something that we have been thinking about and trying to address over the last few years. So there may be many reasons for that. There may be alternative diagnoses like encephalopathy, like metabolic things, non-infectious causes like immune encephalitis, or perhaps more importantly, that the disease patterns are actually changing and there are maybe neurotropic organisms that we haven't thought of. So alternative diagnoses like an encephalopathy are pretty common in unselected samples. In our study, it was like 10%, pretty much similar to the California encephalitis project. Non-infectious causes, now we know, contribute to a fair number of suspected encephalitis cases, immune-mediated encephalitis, especially NMDA encephalitis. So like roughly about 20 to 40% are believed to be due to immune encephalitis. But perhaps the most important thing is that the disease patterns are changing. The landscape of CNS infections is really changing. So why would that be? So that's due to a complex interplay between the organisms, their vectors, the host, that's us, and the environment. The bugs have become really good at adapting, developing mutations, becoming more virulent, and moving over to new areas. The vectors have become like masters in business class travel and jumping from one continent to another. And we, as usual, have gone and messed around with everything, the bugs, the vectors, and the environment, which has resulted in huge changes in the environment, the ecosystems, leading to all this changing landscape of infection. How is it changing? Some illnesses are declining. Malaria, what we saw, HIV, polio, things like that. But there are certain things like TB and Japanese encephalitis. Rabies, don't forget, is a CNS infection, which are just not going away and probably getting worse. But perhaps the more important thing is that some diseases like dengue, melioidosis we just heard about, Chandipura virus in India and Bangladesh, and West Nile virus are re-emerging in a big way. And there may be new infections that are coming in. COVID is a case in point, and the Nipah virus encephalitis, which is in Southeast Asia. And are there new things, new infections that we have never thought of? So there are newer techniques in infection diagnosis like metagenomic sequencing, which has been able to pick up CNS infections, especially undiagnosed, previously not thought of infectious causes in more than 20% of undetected cases. In our study, we were able to identify a couple of such things. One was the detection of Boca virus, which is not thought to be the cause of CNS infection in some of our adults and children, similar to some reports from Bangladesh and a few other reports following that now. And also a small circular single-stranded DNA infection, cyclovirus and semicircular virus, again detected on deep sequencing. So there are probably many things that we are missing. So the challenge of a patient like this in front of you would be that you're going to have a problem in deciding what you're going to do. And largely, perhaps, largely due to the changing landscape of CNS infection. There are a lot of things that we had not even thought of, and there are some things who have been our old enemies, which are re-emerging and emerging now. I briefly looked at the Sri Lankan experience, and we realized our diagnostic yields are low, even with sometimes good external laboratory support. Chances are that findings are same throughout the rest of the world. We really need to develop better diagnostic facilities and to look beyond our boxes, think outside our boxes, and look for different potential pathogens so that we can generate, maybe have some collaborative work to generate multi-center data to guide point-of-care treatment for our patients. So end of the day, ladies and gentlemen, managing CNS infections is a challenge. But remember, we need to do that because early treatment would save lives. Thank you.